Disruption of flow in the arterial level. Mostly transection, laceration, contusion, kink, and intimal flap.
সুলতানের সাউন্ড কি কম শুনছি নাকি আমরা, নাকি এখানে সুলতান একটু
কম শোনা যাচ্ছে?
একটু কম শোনা যাচ্ছে।
Okay, sir.
ঠিক আছে।
Signs of vessel injuries, heart signs and soft sign. Sir, শোনা যাচ্ছে এখন?
Yes, we can hear you. Please continue.
Heart signs.
হ্যাঁ, এখন ক্লিয়ার আছে।
Yes, sir. Thank you. Heart signs, active bleeding, sign of distal ischemia, expanding hematoma, thrills and bruits. Soft signs, hematoma, injury close to the known neurovascular bundles and reduced pulse. In case of late signs of vessels injury, paresthesia or paresis and anesthesia of the limbs. Problems with diagnosing ischemia after trauma. In case of pain due to injury itself or maybe trauma. Pallor due to blood loss, absent pulse due to low blood pressure and compare with other limb. Paresthesia or paresis due to associated nerve muscle injury or unresponsive patients. Investigations clinically. Heart signs, we need urgent intervention, and soft signs observe and investigate. What are the investigation tools? Mainly handheld Doppler, absent Doppler flow, quality signals or ABP we can see. Presence of Doppler flow does not exclude the vascular injury. Duplex scan, difficult to image due to pain, non-cooperative patients and dressings. Patent distal vessels does not exclude the proximal injury. This is the drawbacks of duplex scans. And we can do regional plain X-ray. Investigations, CT angiography, we can see the anatomy, site of injury, soft tissue or bone, and 3D reconstructions. Catheter angiography and arteriography. How soon we should repair? As soon as possible, or effects of ischemia starts, or if, any kind of repercussion injury start. Principle of management. We can firstly resuscitate the patient, assess the viability and extent of the injury, repair as soon as possible, post-intervention monitoring and rehabilitation. Planning. Surgical repair. Repair is done only by the hemodynamically stable patients. We can give the general or local anesthesia, clean the internal limb, and prepare for the limbs for the graft harvesting if required. Surgical repair. Assess the extent of injury. If we need or compartment syndrome, then fasciotomy. Give the along the course of the arterial or venous exposure, longitudinal incision, control of the proximal and distal ends and trimming, balloon thrombectomy, systemic and distal heparinization, interposition graft or direct approximations, if needed, prosthesis. This is the assessment of the injured vessels. If we need regional repairing, trimming, that means trimming if needed, surgical repair, preparing for the prepare for the arterial, surgical repair. Here we done by two type of suturing, modified Carroll or parachuting. Principle of arterial repair. At first we cut the lacerated part and heparinization if depends. Combined vascular and skeletal trauma. Majority of the patients come from the nitor or hair and accidental history, and we sometimes we revascularization first or sometimes skeletal fixation first. Majority of the cases here we depend on the nitor or Bong hospital for fixation. These two hospitals are separate in Bangladesh, and many of the limbs we lost in this region. Primary amputation. In case of primary amputation, extensive crash injuries or soft tissue damage, that is the maglev limb. And in that case, we always transfer the patients from to neuter, because we don't take any opportunity to amputation here, because of transfer facilities and adequate discuss the patients. If we transfer the patient, sometimes give we usually don't give the shunting process in our country. Always refer the patients, and after fixation, then we take the chances of repair. Reperfusion effect. What is reperfusion injury? Paradoxical death of the already dying cells when reperfused. Post-perfusion syndrome, systemic effect of reperfusion. This is the reperfusion and dystonia. When we anastomosis the dying limb or majority of the limbs, chances the reperfusion injury because of ischemia. And when we perfuse, compartmental syndrome, reduced organ perfusion due to increased intercompartmental pressure. Recognize and assessment the limb if needed, fasciotomy and treatment, fasciotomy. Post reperfusion syndrome. What are the post? Acidosis, ARDS, AKI, myocardial depression, DIC, myoglobinuria, and hyperkalemia. How to minimize? Proper hydration, keep oxygen, mannitol, correct acidosis or hyperkalemia, and inotrope support. In hospital, we facility for repair not available. What to do? ABCT, airway, breathing, circulation, and decubitus, and fasciotomy if needed. Discuss the patient party, transfer facilities, and don't apply the tight bandage. Summary: vascular injury, resuscitate fast, assess viability and extent of the injury, assess need for fasciotomy, early intervention and post-intervention monitoring, and rehabilitation. Our experiences regarding vascular injuries at vascular surgery department of NICBT. Upper limb vessels injuries. After repair of the brachial artery by the interposition graft. Every surgeon faces this opportunity to give the interposition graft in our vascular surgery department. Right axillary artery injury. And this is also done by interposition graft, venous graft. Most of the patients from outside NICBD comes in that situation, tight of the vessels. Sometimes we ligate, or sometimes we repair, or sometimes we do the interposition graft because of this ligature or segmental loss. This is another ligature of the brachial artery from outside. Here we repair the radial and ulnar artery, interposition graft. This is the machinery injury in the forearm and hand. In that situation, we most of the cases we don't do anything after wrist joint. Before wrist, radial ulnar artery may be repaired, but we cannot. Most of them cases we cannot repair any small another digital vessels or small vessels. This is an interposition graft of the ulnar artery. This is a traumatic thrombosed brachial artery. In case of lower limb vessels injuries, this is an popliteal artery injury and repair. This is acute limb ischemia due to thrombus in the bound femoral artery. PTA injury after and repair. PTA repair. Sometimes we are too much helpless. In that cases, we cannot do anything for the patient's benefit. because time. Healing is a matter of time, but it is sometimes a matter of opportunity. Thank you, sir.
Thank you, Dr. Sultan Mahmood, for your nice presentation. There will be a question and answer session after the second presentation. Now, I would like.
I want to take time uh, for say for the another interesting case.
ওই
Okay. You
দেখা
want me- Okay. Okay.
Yes, sir.
Please.
স্যার দেখা যাচ্ছে কি?
হ্যাঁ, দেখা যাচ্ছে। আপনি ইয়ে করেন।
ক্লিক করো।
হ্যাঁ, ক্লিক করেন। জি। মানে প্রত্যেকটা
sorry.
হ্যাঁ, জি। ডাবল ক্লিক। সুলতান ভাই ডাবল ক্লিক করেন, হ্যাঁ, তাহলেই হবে।
Last day, this patients with Tata injury comes in our vascular surgery department.
ছবিটা কি করো ইনভার্স করো
এই
যে ডাবল ক্লিক দিলে বড় হয় না
জি স্যার। কিন্তু স্যার এই ছবি yes, this is the Tata injury last day
না না
comes.
আমরা কিন্তু বড় দেখতে পাচ্ছি না
ও
আমরা সবগুলো ছবি একবারে দেখতে পাচ্ছি। আপনি একটা একটা করে ছবি দেখাবেন আমাদের। ওই যেকোনো একটাতে ডাবল ক্লিক করেন, তাহলেই হবে। জি। মানে এটা সময় নিচ্ছে আসলে কম্পিউটারে মনে হয়।
এখন কি দেখা যাচ্ছে বড়?
না না না
না,
এটা কি থ্রি ফরেন বডিজ ওভার দা নেক
জি স্যার, Tata injury, Tata.
লাইকলি টেটা
জি স্যার।
এটা নাকি?
টেটা হলে তো নরসিংদী নরসিংদী না
Yes, yes, your diagnosis is right, sir. স্যার দেখা যাচ্ছে?
না
না,
না
না, ওই মানে আপনার ফোল্ডারটা দেখতে পাচ্ছি, কিন্তু প্রত্যেকটা ছবিতে আলাদা করে আসবে সেটা হচ্ছে না।
কেন?
আনোয়ার কি শুনতে পাচ্ছ আনোয়ার
জি স্যার।
এটা কি মানে এনলার্জ হবে না
হবে, কিন্তু এটা একটু টেকনিক্যাল ইস্যু মনে হয়।
এখন কি দেখা যাচ্ছে স্যার?
না, তোমাকে দেখা যাচ্ছে।
জি স্যার।
আচ্ছা ওই ছবিগুলো নইলে আনোয়ারের কাছে যদি পাঠাতে পারো আমি এর মধ্যে এটা এন্ডোভাস্কুলারটা কভার করি পরে আনোয়ার ওটাকে
আচ্ছা ঠিক আছে স্যার। এই
আনোয়ার
Tata injury, this patient operation done successfully in our vascular surgery department and especially
আচ্ছা, সুলতান ভাই, এটা পরে একবারে শুনবো আপনার কাছ থেকে। এটা আমার
আচ্ছা,
মনে হয় যে ছবিগুলো রেডি হোক, আমরা
Okay,
একবারে শুনবো আপনার কাছ থেকে।
থ্যাংক ইউ স্যার।
তুমি এটা টেলিগ্রামে আনোয়ারকে দাও পরে আনোয়ারই এই যে দেখা যাচ্ছে এই যে
হ্যাঁ, এখন আসছে। এটা কে দেখাচ্ছে?
হ্যাঁ,
আর
এখন
এটা
দেখা-
আমি ডক্টর মাসরুর স্যার, আমি শেয়ার করতেছি স্যার।
ও আচ্ছা বলো হ্যাঁ তুমি করো বলো ঠিক আছে ওকে
জি স্যার।
আর সুলতান স্যার বলুক স্যার।
আচ্ছা ঠিক আছে হ্যাঁ সুলতান ব্রিফ করো ওকে
ওকে স্যার।
মাসুর দেখো হ্যাঁ
This patient comes in our OPD department, emergency vascular surgery department, 26th March 2021, and these patients resuscitate and take care over by our emergency doctors. And next day, 27th, this patient's operation done in our emergency vascular surgery department by our beloved colleagues, especially thanks to Dr. Sajol, Dr. Shantanu, Dr. Jia, Dr. Farid, Dr. Shaun, Dr. Masroor, and so many residents there. They have done sternotomy first and take control of the brachiocephalic trunk. There was a subclavian artery injury and another was a subclavian vein injury. In the supraclavicular incision, they repaired the subclavian artery and There was also thoracic duct injury there, and this patient extubated today's morning. Masroor, anything added?
No, sir. Actually, the patient is from my village, sir. From my village, sir. I am from actually Noshtingi, sir, Raipura. And the patient actually came to me, sir. And I referred the patient promptly to NICVD, and it was actually the credit of the attending surgeons in the emergency vascular surgery in NICVD who acted very promptly, because it's a case of polytrauma, and the dire situation in our country is that polytrauma patients are actually neglected, because polytrauma patients usually need multidisciplinary support. Unfortunately, our medical colleges often don't provide that multidisciplinary support, and specialized institutes usually provides only specialized service. So there's the actually real situation in Bangladesh. So it was very brave on behalf of the vascular surgeons in NICUD to provide the patient with the total care, because the patient had both injury in the apical pleura in left side.
Yes.
If you can see the CT scan, the lateral most sharp pointed end actually pierced the left apical pleura and injured the subclavian left subclavian artery, and the middle one pierced right through to mediastinum, upper part of the mediastinum, and it injured left subclavian vein along with thoracic duct and lima. And the upper, interestingly, the topmost end pierced in between carotid sheath, but how lucky the patient is, did not injure carotid artery. It ended up just behind the thyroid. So it was a brave attempt on behalf of the surgeons.
And at first, Masroor, chest drain given in our department. Chest drain given, then
After
thoracotomy,
intubation, the
stenotomy.
first left side chest drain was given, and blood was noted in the pleural cavity. Then the sternotomy was done. Then the middle sharp pointed end was removed, and promptly identified the subclavian vein injury, the subclavian injury. It was repaired. Subclavian vein actually injured partially. Then the lateral one, which ended up just uh, behind the clavicle, and it actually pierced right to the left subclavian artery, through and through. It was identified and then repaired end to end with approximation by end to end anastomosis. And during its exploration, it was found that left thoracic duct was injured. Initially, attempt was made to repair the thoracic duct. Unfortunately, it was leaking profusely. So decision was taken to tie it up on the both ends. And actually, I was observer from the outside. Active participation was done from by Dr. Sojol sir, Dr. Shantanu sir, and Dr. Jia, as I can recall, Dr. Pori.
All the doctors from Unit 2 was there actually, and all the residents also there. And definitely it was a very brave work from our vascular surgeons side, I think. And we are actually we are very much terrified about the situation, because there are three foreign bodies, sharp pointed foreign bodies are there. And as Dr. Masroor mentioned, that the most upper third, sharp objects that pierced the carotid sheath, we are actually thinking that some carotid arteries are injured. So it was like three separate vascular trauma case to us, and it was definitely a big surgery thought previously, because we have performed hemisternotomy, then the supraclavicular incision, then carotid incision. There was a chest drain, and so I think at the end of the surgery, it was very good because everybody was smiling because patient is saved, and it was a good surgery, I think.
And especially thanks to our great supervisor, new unit chief 3, Associate Professor Nirmal sir. He
He was also
supervised
there.
these cases, and what is the necessity actions he briefed everybody. Suddenly, we are these patients did not have any COVID tests, so we cannot give the opportunity for the cardiac surgery OT or uh, our routine OT, then take decisions in the ABOT. And this is a fallacy for some hours or some moments to go. Thank you, sir.
Okay,
For
I
patient
think
service.
and there is a lot of discussion here, and now Sir Abhidharma sir, do you want to say something? Please unmute yourself. Please unmute, sir. We cannot hear you, sir. Abhidharma sir, we cannot hear you, sir. Please unmute.
You never explained how the patient presented. Was it ischemic arm, or was it has a neurological deficit, or dyspnea because of hemothorax? How did he present to you when you?
Left lung was partially collapsed. Patient was conscious, and there was a low volume pulse in left upper limb compared to right upper limb.
Okay.
Patient was definitely anemic, but 3 units of blood was transfused throughout the procedure.
All right. That's a good job.
So now
which major artery was injured? Subclavian or?
Yes, sir. Left subclavian, sir, and left subclavian vein, sir, both.
Both artery and vein.
Yes,
but,
sir, and the tributaries definitely branches from the subclavian.
It was mainly a venous injury, particularly. Otherwise, if it would transact the subclavian, then patient would be in collapsed.
So, sir, the foreign body was inserted into the subclavian arteries. So, I think that
there was less bleeding.
Yes, sir. That concealed the bleeding, sir.
Now
I'd like to request Dr. G. Mokbul Hossain sir to present his topic, endovascular management of vascular trauma. Please, Dr. G. Mokbul Hossain sir from Ibn Sina Hospital.
Assalamu alaikum. I think all thanks goes to working surgeon, vascular surgeons of the NICBD. Such a great job. This is a difficult case, and they perform this nicely. Again, thanks to all vascular surgeons of NICBD. So the previous speaker told about the open surgical management of vascular trauma. Here we'll discuss about the endovascular management of vascular trauma. It is a common conception that surgery is the only solution for vascular trauma. Nowadays, a lot of vascular problem could be solved by endovascular means.
Excuse me.
Okay, sorry, sir.
Pattern of vascular trauma that could be solved by endovascular means: iatrogenic vascular trauma, renal vessel injury due to PCNL, blunt trauma, pelvic vessel injury, deep femoral vessel injury, a small vessel injury of leg or forearm. So the hardware needed for this endovascular means the covered stent, chemical, that is 1X, NBCA, and coil. This is the picture of covered stent. And this is a case presentation here. Mr. X, aged about 52 years, having renal failure with diabetes mellitus and hypertension. There was an AV fistula developed between left proximal SFA and SFB during insertion of dialysis catheter. So the hardware used here 8 French sheath, O35 means wire, 7 millimeter balloon, and 10 millimeter by 60 millimeter covered stent. This is the procedure. We can see here this is the AV fistula between left superficial femoral artery and vein. This the DSF shows nicely. There is a communication between proximal SFA and this is deep femoral artery. This is superficial femoral vein. Here we can see this is the deep femoral artery. This is SFA. This is proximal SFA, and this is communicating with the superficial femoral vein. So the communication is here. This is the communicating point. So still the picture shows this is deep femoral artery, this is superficial femoral artery, and this is the communication. We can see the run. And with the help of 7 millimeter balloon, we confirm, yes, this is the communicating point. This is the inflated balloon. This is the deep femoral artery. And we can see no dye is going to the SFA. And there is non-visualization of the superficial femoral vein. So this is the culprit site. This is covered stent, 10 millimeter by 60 millimeter, and this is the deployment of the self-expanding covered index. This is the fluency prepared by Bird, and we can see this is the deployment of the distal part of the covered stent. It is deploying. Then the final part, yes, final part, this deployment of the covered stent is over. This is the last part. And after deployment of the stent, this picture, this is deep femoral artery, this is the SFA, and now there is non-visualization of the superficial femoral vein. So there is no communication now, problem is solved. And this is the completion angiogram. We can see the SFA and the distal run. Now the chemical embolization. Here the NVCA agent is used with lipiodol. Here lipiodol is as a contrast. And another option is injection onyx. Onyx itself is a glue as well as it is a radiopaque chemical. Properties of NVCA. This is a liquid substance, becomes hard and adhesive when in contact with water, blood, or anion. This is NVCA. The trade name is endocril. Properties of injection lipiodol. Lipiodol is a contrast. It is a oil-based contrast. It provides visualization of NVCA. It also dilutes NVCA. This is the lipiodol. Lipiodol is costly. Cost around is, one ampoule cost around is 15,000 to 20,000 taka. This is the NVCA lipiodol mixture. It depends on size of blood vessel, flow in blood vessel, operator's experience, usually 1:2 or 1:1 ratio. Here is a picture of procedure post PCNL hematuria managed by chemical embolization. This is the hardware 6 French Judkins catheter, microcatheter, NVCA, and lipiodol. Here we can see extravasation from left renal artery branch. We can see some sort of extravasation is here. This is blush. We can see the right picture. We can see also this is the showing there is some sort of extravasation here. And selective angiogram by microcatheter. Yes, we can see this is the culprit artery where there is extravasation. This is microcatheter. This is 6 French Judkins catheter. The small size is microcatheter, and this is the site of injury. On the right hand side, The picture shows so now the deployment of injection NBCA and lipiodol. This is the deployment. This is not the usual contrast. Rather, this is the deployment of the glue. This is NBCA mixing with lipiodol, and it has occluded the culprit bleeding vessel. And the DSA on the right side completion angiogram showing yes, there is no extravasation on the apical part of the left kidney. So this is a completion angiogram, and there is no extravasation. And the right hand picture we can see actually this is the arterial tree. It is the radiopaque injection NBCA and lipiodol. It has occupied the vessel, so this artery is already occluded. And last of all, there is no extravasation and there is no bleeding. So no extravasation, and the problem ultimately there was no hematuria and patient was settled. This is another important agent. This injection Onyx. This is chemically ethylene vinyl alcohol adjoining with DMSO. This is dimethyl sulfoxide. It acts. This agent is acts as a priming agent. This is the Onyx.
Onyx is a non-adhesive liquid embolic agent comprised of ethylene vinyl alcohol copolymer, EVOH, dissolved in dimethyl sulfoxide, DMSO, and suspended micronized tantalum powder to provide contrast for visualization under fluoroscopy. The Onyx liquid embolic system consists of a 1.5 milliliter vial of Onyx, a 1.5 milliliter vial of DMSO.
This is DMSO.
One yellow 1 milliliter DMSO syringe.
It is the delivery syringe.
And two white 1 milliliter Onyx delivery syringes. Onyx is available in two product formulations. Onyx 18, 6% EVOH, and Onyx 34, 8% EVOH. Prior to injecting Onyx, load the Onyx mixer with 4 vials of Onyx
Shaking
and
of
shake
the
for at least 20 minutes
Onyx
at a setting
injection.
of 8. Continue mixing until you are.
So another option is coil embolization. Different coils are available in the market. To occlude the artery, this coil is utilized, and the pelvic vessel injury treated by coil. This is the picture, book picture, nothing else. Traumatic posterolateral artery also injured treated by microcoil. This is book picture also. So take home message: endovascular management of vascular trauma is a new chapter for vascular interventionists. Cath lab facilities and hardwares are mandatory. Hybrid cath lab, where cath lab plus operation theater is an ideal place for vascular trauma management. Thank you all.
Thank you, sir. Thanks a lot for your nice presentation. Now, I would like to invite questions from the audiences. You can put your questions in our chat boxes in Zoom. Also, can raise your hand so that you can ask your questions. And I would like to request Dr. J. Mokbul Hossain sir to conduct the question and answer session.
Now the session is open. আমার মনে হয় যে আমরা প্র্যাকটিসিং ভাস্কুলার সার্জন যারা আছি প্রত্যেক ইচ অ্যান্ড এভরিওয়ান ইজ এক্সপোজড টু ভাস্কুলার ট্রমা। তো এখানে আবিদ স্যার এখানে আছেন, মাহবুর রহমান স্যার জয়েন করার কথা ছিল, ডক্টর বজলুল গনি ভূঁইয়া সিনিয়র যারা আছেন, ডক্টর এনামুল হাকিম ওনাকে দেখছি, প্লাস আদার্স কর্নেল হুমায়ুন কবির, যে আমরা আবিদ স্যার ওখানে আছেন। যেসব করছে বার্নিং ইস্যুগুলো অথবা যেগুলো আমাদের conflict যেসব জায়গাতে আছে, we can ask the question without any hesitation, and আমার মনে হয় যে this is the great opportunity for us to solve that questions. Now the session is open for question and answer session.
Thank you for nice and elaborate presentations. একটা জিনিস আমি সুলতানের কাছ থেকে শুনলাম যে পেশেন্টস যাদের কিছু করার থাকে না কিংবা failure of the procedures after revascularization, those who need amputation, ওখানে NICBD তারা কিছু করছে না, আবার পেশেন্টকে ব্যাক করতেছে নিটোর কিংবা অন্য জায়গায়, পেশেন্ট গুলো আসলে নিটোরে সব যে পেশেন্ট যায় তা না, এগুলি কিন্তু মেল হ্যান্ডলিং হয়, বিভিন্ন জায়গায় যায়, বাট পেশেন্ট সাফার্স। Why NICBD does not have amputation? It's a very simple procedure for patients.
Sir, thank you, sir, for your nice question. In that situation, most of the we referred that patient because of overloading our
Patient
native patients.
overloading.
Patient overloading in vascular trauma patient overloading. If we go for the another amputation or another, then it's time consuming and take another OT. We have only one OT. Still now we have only one OT, emergency OT. So we should have to refer most of the patients in Nitor or Dhaka Medical College. In Dhaka Medical College, there is also a
What
vascular
about
department, and
another
also
relevant
Nitor,
question?
there is a vascular department still now.
What actually they are doing?
স্যার এখানে আমি তো সাপ্লিমেন্ট করতে চাই, আসলে অর্থোভাস্কুলার যে কাজগুলো আছে সেখানে আমাদের এখানে স্কোপটা খুব লিমিটেড, কারণ সাফিসিয়েন্ট ইনস্ট্রুমেন্টেরও কিছু গ্যাপ আমাদের আছে। আর যেটা আমাদের বললেন যে আমাদের সুলতান মাহমুদ যেটা বললেন সেটা হলো যে আমাদের যেহেতু উটির একটা উটি এবং টাইম কনস্ট্রেইন আছে, আমাদের নিজস্ব অনেকগুলো পেশেন্টের জন্য আমাদের হ্যান্ডেল করতে হয়। এখন
This
টোটাল
is for
বাংলাদেশেই
NICBD.
স্যার, টোটাল
This
বাংলাদেশেই
is
তো স্যার
for
পেশেন্ট
NICBD.
স্যার এটা তো মিসহ্যান্ডেলিং সারা বাংলাদেশেই আছে। এটা তো আসলে এনএসিবিডি থেকে আমরা এটারে পাঠাচ্ছি বা সুরাটি মেডিকেলে পাঠাচ্ছি।
আমি জানতে চাচ্ছিলাম যে নিটোর হ্যাভ বিন আপগ্রেডেড and it is a very big institution, নিটোর, and they have opened a vascular surgery department. What they can do, what they are doing there for vascular trauma or orthopedic traumatic patients having vascular injury, what they are doing there?
আমার মনে হয় কি আমাদের ডিসকাশনটা আমরা একটু একাডেমিক জায়গাতে আমরা থাকি, ইনস্টিটিউশনাল যেগুলো এগুলো একটা বোধহয় সেপারেট এন্টিটি বা সেপারেট জায়গা, উই ক্যান ডিসকাস ইন অ্যানাদার সেপারেট সেশন। কম্প্রিহেন্সিভ ভাস্কুলার কেয়ার ডেফিনেটলি আমরা এটা চাই, আদারওয়াইজ অন্য ইস্যুগুলো যেগুলো একাডেমিক জায়গা সেই জায়গাটা কভার করি, এটা বোধহয় ডিফারেন্ট সেশন উই ক্যান ডিসকাস।
Besides that, I think there's an issue